So for this next section, we want to talk about the AV junction and the junctional rhythms that are often associated with it and some of the other problems and things we can see. So when the SA node stops being the primary pacemaker, it either doesn't fire fast enough or doesn't fire at all, the AV junction will take over. And if you remember in some of your first cardiology studies, the intrinsic firing rate of the AV junction is lower than that of the SA node. So one of the things we often see with these is somewhat of a slower heart rate. The way we typically identify a junctional rhythm on the ECG is that there is a complete absence of P waves, or we have inverted P waves due to what's called retrograde depolarization of the atria. So remember that the atria will follow any command to depolarize, whether they get it from an individual atrial cell or whether that comes from the AV node instead of the SA node. So what you actually see in this case is an inverted P wave because the AV node fires and the atria fire backwards, so to speak. They depolarize backwards, so you get an inverted P wave out of that. Generally, the Qrs complex is of a normal duration, so it's less than 0.12 seconds. The PR interval, if you have one, is generally less than 0.12 seconds, which is abnormal. And the reason is, of course, the SA node is not sending a signal down to the AV, who is then pausing. The AV node has completely taken over, so your PR interval is less than normal, which is, of course, abnormal. When you see this type of thing, it can be a result of long-standing heart disease. It can be a result of an active MI, that the SA node is kind of being choked off, or SA node ischemia. There's a lot of pathology behind it. Your patient's hemodynamic stability should dictate how aggressively you treat it. With these, you can also see what are called premature junctional contractions. So these are electrical impulses that originate in the AV node and they occur before the next sinus beat. So this is one of the things you can see where if you have some sinus beats going on, you can actually see the heart sort of beat one time in between beats. And what makes this different than what we've discussed before is there is usually a pause immediately afterwards. So there's a compensatory pause. So if you could kind of imagine a heart that is beating normally, so it's beat, 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 and then it'll have a beat that is too early. So beat, 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 and then it'll pause. So it'll be beat, 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 and that's just, again, this is an audio lecture. I can't show an EKG to you while you're driving. So you can see PJCs in people that use caffeine, tobacco, alcohol. Of course, the sympathomimetic drugs can aggravate or excite this, so methamphetamines, cocaine, ecstasy, so on and so forth. You can see it in ischemic heart diseases, digitalis toxicity. Again, a lot of heart problems caused by digitalis toxicity if you haven't seen that yet. They can also be completely idiopathic. Now, remember that idiopathic doesn't mean benign. It just means we don't know why it's happening. Often enough, idiopathic happens and it's benign, but idiopathic doesn't guarantee it's benign. So frequent premature junctional contractions, they indicate a problem. They indicate heart disease, and they may be precursors to other junctional arrhythmias, which we are going to continue into here. So the first that we'll talk about is a junctional escape beat. So the rate of the pacemaker, the primary pacemaker, which is usually the SA node, is going to be slower than that of the AV node, and the AV node becomes the pacemaker. This is a safety mechanism that prevents cardiac standstill. So you can just kind of see a beat come out of nowhere with that. Also, there's problems with vagal tone, pathological slow SA node discharge, or heart block, and the heart is thinking it's ischemic, or the heart is ischemic. This entire process can decrease cardiac output, which can result in ischemia and thusly angina. So you can have patients that have pain with this. If there's signs of poor perfusion, they get paced. So if there's signs of poor perfusion here, since we can't guarantee that the SA node is doing all it's supposed to, we don't go with atropine here. Generally, pacing is what we do. And these are those patients that are kind of stable enough where you hear about sedation before pacing. These are those patients that are often enough stable enough to be sedated a bit and be paced. And usually that sedation will happen with midazolam, just a small amount, and check your local protocols. But 2 milligrams is usually enough to kind of knock the edge off, because this will be somewhat painful, or maybe the word is discomfort. Generally, patients who are awake and being paced are unhappy. So you give them something to take the edge off that doesn't put them to sleep, but helps them relax and deal with the discomfort of the procedure a lot more. So let's move into the actual rhythms and talk about junctional bradycardia. So in order for it to be a junctional bradycardia, the rate has to be less than what the AV junction can commonly put forth. Now, if you've been in your books and study, and you know that the usual rate of the AV node is 40 to 60 beats per minute. So when we see a junctional rhythm that has a rate of less than 40 beats per minute, we know we have a junctional bradycardia. So the biggest problem with this is that it compromises cardiac output. A heart rate of less than 40 beats per minute is not often something that can sustain life, that can sustain mentation and things like that. The heart, as well as the rest of the body, becomes ischemic, and your patient can present with signs of shock. This is going to be the cardiogenic shock you hear so much about. This can come from vagal tone. It can come from a pathological slow discharge of the nodes in the heart. It can come from heart block. The biggest thing here is you're going to have to speed the heart up. You can try atropine with these. It's generally not like all that effective. The usual route for this is pacing. So the usual therapy for this is pacing. And I will refer back to Francis Schaeffer, who said the only absolute allowed is the absolute insistence. There are no absolutes. So you will see it done differently in all areas of our nation, and indeed the world. But you very often get good results with pacing, and sometimes you get less than desirable results with chemical or pharmacological intervention. Maybe that's a good way to say it. You can also see an accelerated junctional rhythm, which is sort of the opposite of junctional bradycardia. So you have increased automaticity in the AV junction at this point, and this causes the AV junction to discharge faster than its intrinsic rate. So this is what usually messes with people a little bit, because when we say things like tachycardia or accelerated, we tend to think of a faster heart rate. This is not going to be all that fast of a rhythm, usually. What it is going to be is faster than the intrinsic AV node firing rate. So you're going to see something that's faster than 60 beats per minute in this particular one. So that is one of those where you're going to see a junctional rhythm faster than 60 beats per minute, faster than 80 beats per minute, things like that, where you generally have a rhythm that can be perfusing. It may or may not present with angina. It may or may not present with any instability at all. But for whatever reason, the AV node is is firing faster than it usually does. That wraps up the basics of our AV node dysfunctions, and we will move next into ventricular dysrhythmias, which are by far where we treat the most aggressively. So it's going to be a lot of fun.